there's probably 4 very large level 1 studies showing, like Framingham study that just says, hey, you do this arthroscopic meniscectomy and people are normally worse.
You're listening to the Ethos Athletes Podcast, where we believe that your health is the number one resource you need to accomplish your dreams. My name is Dr. Matthew Hernandez, and I'm a physician dedicated to helping my patients maintain their active lifestyle and continue doing what they love. I'm sitting down with other experts so that we can provide our listeners with the knowledge they need to improve their health and live their best life. Hey everyone, this is Dr. Matt with the Ethos Athletes Podcast, and today we're going to be continuing our series on regenerative medicine for the treatment of joint pain. Today's particular episode, we're going to be discussing using regenerative medicine to treat knee pain. For this series, we have brought on special guest Dr. Kellum, who is an orthopedic surgeon, regenerative medicine specialist, and the owner of Nashville Regenerative Orthopedics. Dr. Kellum was also the former assistant team physician for the Boston Celtics. Dr. Kellum, welcome back to the show.
Hey, Matthew. Thank you for having me. I appreciate it.
We've discussed using regenerative medicine, which is platelet-rich plasma or PRP therapy and stem cell therapy for the upper extremity, where we've talked about shoulder, elbow, wrist, and hand. And today we're going to be discussing the knee, as I mentioned before. So the format that we've followed thus far has been patient walks in with joint pain of the knee this time, and what are the different things that could be going on? How have they traditionally been treated? What are the pros and cons to that? And then what have we seen as far as regenerative medicine in my practice and in Dr. Kellum's practice as well? Dr. Kellum, patient walks in with knee pain. What could be going on?
Yeah, so the knee, there's so much around the knee, and it's one of the most, besides probably the back, it's going to be probably the most common place that people are going to come in, what people are going to come in to be seen for. And so, as always, history and physical are key. And then I'll tell this one quick story, and then we'll get more into, what's around the knee.
Yeah.
But when I was doing straight orthopedics, where, I would see 40 plus patients in a day and 2 days to 3 days a week operating on call and all those things. And I realized that there was a time when, 5 minutes or 10 minutes with a patient was a long time. And so, it was what I had always known. It's how I was trained and it's what I did. And then when I started doing regenerative medicine and spending more time with folks, I realized that they were seeing people and being diagnosed with one particular injury, and that like, oh, you got knee arthritis. When really it was like their IT band or something like that. And they'd been set up to have a total knee because they were having issues with their IT band. And so, history and physical is very important. And obviously the patient is going to tell you what's wrong with them. It's at times it's not rocket science. And so if you listen to them, if you do a good history, if you do a great physical and figure out really where are the pain points coming from, then you're gonna find out a lot of things, and when you know more, you'll be able to help your patient better. So that's obviously key, right? So doing a great history, doing a great physical, and having good image. I always like to have X-rays, and I always like to have MRI. I think those things are very, very important because it's going to give you a good sense of what's going on. And not always, some people can have issues on the MRI, but it doesn't mean that that's their problem. So you really have to have some clinical judgment when looking at that. But actually, what they do, did they injure it? How long it's been going on? When does it hurt? And then, what treatments that they've, had in the past. But, the knee, you kind of going through things. You can have quad tendon issues. You can have patella tendon issues. You can have meniscal problems. You can have OA. You can have cartilage lesions within the joint. You can have Baker cysts. You can have lateral collateral ligament problems. You can have medial collateral ligament problems. You can have ACL problems. You can have posterior cruciate ligament problems or PCL problems. And even some problems of the nerves around the knee. So there's a whole host of things that could be going on with the knee. So you really want to give get a good physical exam and a great history to really help you understand what's happening, where their pain is coming from.
And that's where that SANS approach that we talked about before really comes into play, right? Like yes. that takes into account everything that you just mentioned.
Yeah.
And that's something that we both use and have seen successful in helping us figure out what's going on with the knee, essentially.
Correct. Yeah. Alignment's off. If stability's off, if the neuromuscular the nerves are off or the muscles off. People will have what we call patellofemoral syndrome pain.
Yeah.
And everything in the knee looks great, but they'll have an issue with their vastus medialis is just not strong. That one, point on the knee, so their muscle is not as strong as it is on the other side, can cause that pain there. And when they can, balance that out and they can strengthen that muscle inside, the pain goes away. It's amazing what happens when the stability is a little off, if the alignment is a little bit off.
Yeah.
What that will cause. And so, really understanding that is pivotal for patients.
Yeah, and I think it's also important to note as well. And I don't know if you've seen this to be true, but at least in my practice, the knee is almost always a victim of something that's going on, up or below or up the chain, right? So it's either some sort of hip problem that caused to be an issue, or foot and ankle problem that caused the knee to be an issue. Like there's something in the chain that is causing it to be the problem. It's rare that the knee is solely just the only thing that's injured. It was, it got injured because something was going on.
You're absolutely right with that. It's amazing if if you're treating knee pain and you're not thinking about the hip. Once again, you're not doing a good job. If you're treating knee pain, you're not thinking about the ankle. It's the same deal. And so that's very true. See that all the time. And there's sometimes when, especially I've seen it in kids, they'll present with hip pain, but it's really their knee.
Yeah, exactly. Absolutely. So let's talk about, I think the one that our listeners are probably going to be the most familiar with, and we'll start off with this one, because it's probably the easiest one, is arthritis.
Yeah.
And so, like you said, a lot of patients or a lot of people will go in, they present with knee pain. They're immediately told, oh, you just have arthritis. And sometimes that's the case. Sometimes it's not. But let's say that it's the case in this story. And usually the arthritis got caused from some sort of asymmetry that's going on, going back to that SANS approach. And the knee just kind of got worn down because a muscle was weak at the hip, or some pelvic alignment was off, different things like that. What are the common treatments that are used in treating arthritis from an orthopedic perspective?
Yes.
How has that evolved since then?
Yeah. So arthritis, arthritis in the knee is a very interesting thing because, arthritis, all arthritis essentially is a loss of cartilage, and the formation of bone spurs and things like that. And it's really actually much more about that. And we'll discuss that in a moment. But the treatments that people are going to have is, number one, they could say, well, gosh, let's inject your knee with a steroid, right? And we've discussed extensively on this program about steroids and the damage that it causes to joints and the diminishing return that you have from multiple injections. And so, although steroids is an option, it may be best to stay away from that. One injection may not be a big deal, but definitely multiple injections you want to stay away from, just because ultimately it's going to hurt your joint, cause more damage and problems. And then someone could say, well, gosh, let's do viscose supplementation. And viscose supplementation is a great treatment because, one, it doesn't hurt your joint, and two, people will actually experience some relief from that. Not all, it's maybe 50%. And there's definitely research that's for it and research that's against it. But one very little downside to it, and something that could potentially help. So that's a great one. Physical therapy is one that ought to be started in the very beginning. It ought to be something that's done. And then PT can go a couple ways. I think for the far majority of when physical therapy is done, it does help because you're strengthening those muscles. You're helping the stability and with the modalities that they have. And so as long as you have a very a competent therapist that really understands that knee joint and can help make that better. And then you get into things like braces and sleeves. I'm not a huge bracer in a lot of situations. I do believe a lot in sleeves, especially sleeves that can help with making infrared and things like that, and bringing blood to the surface. That can, I definitely believe in doing that. And then you have things like taking anti-inflammatories, right? Or even pain medicine. Of course, pain medicine, we have an epidemic in this country of using opioids. And so we want to stay away from that. NSAIDs are not benign because they're going to, can affect your kidneys. They can affect your belly. Anybody that has GERD or, high blood pressure should definitely stay away from anti-inflammatories. So, although those are options, are not, not great options. And then you have even things like doing surgery. And so one of the most common things that I see as an orthopedic surgeon, and one of the things that I used to do that I don't do anymore, is I used to, I'd see that 50-year-old patient that's got, he's got some arthritis, he's got this meniscal tear, and I'd say, well, gosh, we just need to go in there and clean it up. Right. And so what happened, the majority of the time was you go in there and clean it up, and it actually made things worse, because now you've got less meniscal tissue, and it actually makes the stresses across the knee worse. And so, once again, an option, but not a really good option. There's definitely, other things out there that can do besides the very traditional things that we've done in orthopedics for this.
You mentioned cleaning it up and getting it scoped, or, there's a bunch of different ways that people term that. So let's talk about why that's not the best thing. And maybe start off with saying, if you could give us an idea of the purpose of the meniscus and why it's there, and then show us why removing it isn't the greatest thing in the world.
Yeah. So the meniscus they're C-shaped cartilage cushions that live in between the thigh bone, the end of the thigh bone, the femur, and the end of the shin bone, the tibia. And so they absorb the stress as you walk, run across that knee. And so when those things are nice and healthy, there's that the stress that goes to the femur, that goes to the tibia, the thigh bone, the shin bone, are decreased, and it keeps that cartilage nice and smooth, and things work well. And so you can imagine if you were to take part of that meniscus out, right? You go in there and it's like, I'm just going to shave a little bit of this out. Now the contact stresses that you would normally have, they're now different, right? And so now that thigh bone or that shin bone is going to see more stress now. And so when there's more stress, then that tissue wears out faster, it damages faster. And the interesting thing about a knee joint or a ligament or a tendon is there's not a ready blood supply to that, like our skin, right? We cut our skin, things heal immediately because the blood gets there, platelets and all that stuff. And platelets they help clotting, but they also have the growth factor in there that helps things heal. Right. When the cartilage gets damaged, blood can't get into the joint, just the way we were made, right? And so that cartilage then wears out over time. And so when the contact stresses are different, the cartilage then wears out, and then there's all those problems that ensue. So meniscus tissue preservation is very important. I always like to think about save the meniscus. Yeah. And no matter if it's damaged, and there's a difference. If you're a 20-year-old and you have an injury where you tear that, then we probably ought to try to repair it. Versus when I'm, older and I see this meniscal tear, which is probably a degenerative tear. It's probably better to leave that tissue in there versus taking it out, because we definitely are going to make the stresses across the knee, and then hasten your time to get arthritis.
Yeah, for sure. Now, there's also times where people can have like that flat tear with a meniscus. Would that be a time that surgery would be indicated, or can that be treated?
Once again, it depends. If it's if it's in a younger patient and it's causing where you got this catching, this locking, then that may be a time that you want to potentially evaluate what you do with that meniscus. And what I would say in those situations, even if you get to the point, a younger person is different than someone that's in there, 45 and above. Not to say that 45 and above is old, not saying that at all.
I didn't hear that.
But yeah, you didn't hear that at all, because I'm close to that age. But it's going to be a little bit different, right? I had patients that I see kind of those tears, but I can help them and make them better with a regenerative procedure versus going there and cutting that out. And once again, even backing up from there, if I see that the question may be, do I need to try to repair that, augment it with something regeneratively versus cutting it out?
Right.
Because I know when I cut it out, I'm going to make those stresses different. And when those stresses are different, it's going to it's going to make things worse in the long run. And you always have that patient or two out of 10 that's going to like, well, I had it done and I feel great and it worked fine.
Yeah.
And that is what I would say is that is not the norm.
Speaking of norm, how common is it that this procedure is still done?
Oh, arthroscopic meniscectomy, it's like the number one orthopedic procedure.
Yeah. It's still, it's a bit, doctors are doing it, even though it's showing that it doesn't help as much, right? But
there's probably 4 very large, level 1 studies showing, like Framingham study that just says, hey, you do this arthroscopic meniscectomy and people are normally worse. What I've normally seen patients do, and a couple of things happen, like especially now that I'm doing a lot of regenerative medicine, is patients, they'll come in and they'll say, gosh, after I had that meniscectomy done, my knee was worse.
Mm-hmm.
And that's usually true. They'll also say, well, gosh, I had that meniscectomy done, it was worse, then I had a total knee. And then I'll go, and I'm not going to have a total knee on this other side.
Yeah.
And I'm not, once again, I'm a surgeon. I believe in surgery. I think there are times for that. And total knee surgery is a very good surgery. It works very well for 7 out of 10 people.
Right.
And there's sometimes when you need that. But those 3 out of 10, when you're dealing with needing to have a revision, right? When you've had that MI or that blood clot or those things, or it still hurts, those problems, it's definitely not benign. And once again, I'm not, as a surgeon, I believe in surgery, but there are times that we can get you where we want to go without operating. There's a very good study by a surgeon out of France that has looked at in comparing people that had a total knee on one side and then having a stem cell procedure on the other, comparing the two. And what he found is that people, one, got down the road without pain, and they preferred the knee that they had the stem cell procedure done in. And this was done by an orthopedic surgeon in France.
Cool.
It's very interesting data.
Yeah, absolutely. So then going into the regenerative medicine aspect, so we talked about all the treatments that exist currently for arthritis, and now we'll go into like the newer treatments, which is PRP stem cell.
Right.
We both discussed, and we both have had success with treating arthritis with regenerative medicine. But let's talk about, when you're looking at arthritis, there's mild, moderate, severe. Have you seen any more success with one over the other? Are they all even across the board?
Well, definitely I think when you're looking at something that's mild and moderate versus something that's severe, those folks have a better opportunity to respond. And not to say that someone that has severe will not respond, because they do, but just, anecdotally, it's a little tougher the worse that it is, but it's not, doesn't mean that it's, something that can't help.
No, that's perfect. Now, when you're going and treating the arthritis, obviously you want to make sure that you're addressing still that, you're doing your regenerative medicine injection. The result you're seeing, I'm assuming, is decreased pain and increased function, right?
Correct. Yeah.
And you obviously want to make sure that you're going and still addressing the weak hip muscle, whatever it was that was causing some of these problems as well, and completing the whole picture.
Yeah. So that's why physical therapy is very important with someone that understands how, to treat patients and things, because you just got to look at it all, right? You can't treat someone just from a silo. Like, oh, we're going to put this in your knee. You have to look at, quite honestly, hormonal things and diet things and activity things and strengthening other joints to make sure that this joint that's really having the issue can be the best that it can be.
Have you ever used like a combination of platelet-rich plasma or stem cell injection with hyaluronic acid?
Yeah, so that there's some good literature out there that supports that, and there's some literature out there that says that doesn't, that may actually hurt things. And I've tried that on a few patients and to see, but hyaluronic acid is something that it's the building block for cartilage, and right. So if you're doing something that's going to have the cartilage be better and stronger, it's great to have building blocks around. That's kind of how I see it. And so
Yeah.
We definitely have our protocols, the way in which we do it, which doesn't often include, or usually doesn't include hyaluronic acid, but that's a great, potentially a great treatment tool to use.
Cool.
To use
Perfect.
those in conjunction with one another.
Yeah, and that's kind of been my experience as well. As most of the time, I'm able to get them better, usually with just PRP. And so I'll go and do my series of PRP treatments, and then every now and then, by the end of the treatment, they'll say, "Okay, well, it's like the pains went from an 8 to a 10, from an 8 out of 10 to a 1 out of 10." And if that 1 out of 10 is still there, it's like, okay, well, let's just try HA injection and see if that helps with it. And then, sure enough, that's what gets rid of the rest of it. So as opposed to a whole other PRP treatment, it's a little bit more cost effective that way.
Yeah, that's a great way to do that.
Now, we discussed arthritis. What's the next thing for the knee that walks into your office after arthritis?
So definitely arthritis is going to be the biggest thing, and meniscal tears all kind of include that in arthritis, because most of the time people have a degenerative tear that's there. But the next things that you're going to treat around there are things like patellar tendonitis, quadriceps tendonitis, ACL sprains, even potentially tears. That can be really helped with doing regenerative procedure. And those things often, folks are like, well, gosh, there's nothing I can do about it, kind of live with it. But that's not the case with these things. And, the ACL is kind of a little bit of the holy grail in the knee as far as regeneratively, because one, a lot of people don't do it. There's very few people that will inject an ACL. But you've got to, especially if you're a young kid and you've got a strain to that, treating that could help significantly, and also prevent, arthritis down the road. And then, like I said, we mentioned quadriceps tendonitis is big. Patella tendonitis is big, folks that are having those things. So that's, those things can be helped tremendously with the regenerative procedure.
Well, as far as ACL, quad, and patellar tendonitis, what are the common treatments for that? Is it still cortisone that's done orthopedically for that?
Yeah. So, people, around the quad tendon or the patella tendon, they'll try not to, because it's such a big tendon. If that were to tear, in which cortisone would help it do that, they try not to inject that around there. But, you'll use things like bands around there, physical therapy, taking anti-inflammatories to potentially help that. And some of those things can nag for a very long time. They just don't get better. And then obviously there's also, surgical procedures for that. There's been plenty of times over my career where I've gone in and debrided a tendon with a scope, especially like a patella tendon or something like that. And that helps. But, you've done this big surgery and now scar tissue and all these things. And so there are those treatments out there. But, once again, looking at a regenerative procedure where you've got this damaged tissue, it's a tenotic, tenosis, and it would heal if it had the cells to help it. And so essentially with regenerative, material, we bring that to the ball game to help it do its thing, and it works beautifully in a lot of people. Yeah,
no, it's really good. Going back to the meniscus really quick, when in a degenerative tear, are you expecting it to heal, or does it just help with the pain? It's not going to heal 100%, that's for sure.
Yeah, it can. To say that to someone, I'm not going to say, oh gosh, we're going to totally heal that, because if you have two ends that are apart, it's going to be hard to get those two ends together, right? Without putting a suture or something like that in it. So it's not about the healing, but it's more about the decreasing the pain, right? So stem cells and PRP, in which this is one thing I think that we as physicians, we need to explain a lot better, is that sometimes it's not that we're going to make that structure better, but sometimes we're going to make what is in the knee that's causing pain, we're going to make that go away. So we know very well, and I think we talked about a little bit in the shoulder program, we talked about how that you can have an arthritic picture as far as and it could be bad looking arthritis. They don't have, patient could not have knee pain.
Right.
And so we know that there's something in the joint that's causing that pain, right? And they have names, these factors like metalloproteases and IL-1 and all these things that will increase the amount of inflammation and pain within a knee joint. And so stem cells and PRP, when they get into the joint, they find those things, kind of bind them up, get rid of them. And so when those things are gone, now your pain is decreased, your inflammation is decreased, and then therefore your function is better. Your MRI and X-ray may still look pretty bad, but you're like, I can do all the things I want to with this knee. And that's really how stem cells work. And definitely, does it regenerate things to some degree? Yes. Does it heal some things to some degree? Yes. But it really works in those first two ways right there that we talked about.
Yeah. No, I think that's a really good distinction to make. And I get some people who come in and we determine they're a candidate for the treatment. We do the treatment. And then, in between treatments, they'll go and start Googling and reading stuff. And they read stuff about, it's, cured 100%, all those other things. And so they want me to do an image and like, I want to see it, how it's completely healed. It's like, well, you're not going to see that right away, one. And two, keep in mind that, we're wanting that, yes, but what we're more interested in is decreasing that pain, increasing your function, making sure you can safely get back to doing what you want.
And there's so many times when you see folks, they'll have a bad looking X-ray and they just don't hurt. And, and that's because there's something going on in the joint that's causing that pain, not just the arthritis that you see.
Right. Yeah. Don't treat the image, treat the patient.
Right.
So we discussed that part. That one of the injuries, or one of the things that I commonly treat as well in my office, is going to be medial and lateral collateral ligaments, which kind of, as help with the stability of the knee.
Right.
Had experience treating those, and what's your experience been with it?
Yeah. So, for every knee that especially a knee with arthritic picture, I always treat the MCL, the LCL, because those are the some of the main stabilizers of the knee. And one of the interesting things that I've always found, that when I see patients that have arthritis and then we're treating them, is that tissue, when I'm looking at ultrasound and I'm injecting either Prolos therapy, stem cells, or PRP, or things like that, that tissue is always incompetent. See it, it's there, but when you inject it, it's just, it's soft. It's not as tight as it should be. And that, at first was very, very interesting to me, because it shows you how you have this micro instability, right, that can then cause arthritis, and then therefore at times cause pain. And so if you're not addressing that stability part of the sands, you're kind of throwing some stuff in the wind at times. So you really want to, when you're having these things done as a patient, or you're doing these things as a caregiver, you don't want to forget about the MCL and LCL. And I think that everybody that has anything done with their knee ought to have those things injected. Yeah,
absolutely. I think it's overlooked, certainly in the, especially in the orthopedic world, where they're just doing the cortisone shot. It's definitely overlooked, and not fixing that, or not tightening and stabilizing that a little bit more is you're not helping anybody.
Yeah, I agree 100%.
Now you're, what do you call it? Are you using when you're going, so let's say someone has arthritis, when you're going and injecting the MCL, LCL, are you also using stem cell PRP, or are you doing prolotherapy for that part?
I'm doing a lot of prolotherapy for that, but it kind of depends. There's definitely, if you can put some PRP in those things, and even some stem cells. I try to reserve the stem cells for the inside the joint.
Right.
And so, but a lot of prolotherapy for the ligaments.
Yeah, and I mean it works just fine for that. I mean that's what it's made for. Is injecting those ligaments and tightening those up. So,
yep.
Cool, perfect. Dr. Kellum, is there anything else you'd like to add on the knee so our listeners can take home?
No, I mean, the knee is definitely, there's a lot going on that's there, and obviously doing things to protect your knees, your diet and nutrition that you have, and doing some of the other modalities. But, knees can cause a lot of problems.
Absolutely. And they're fun to treat.
Yes. Yeah.
I think we threw a lot out at y'all today. So, Dr. Kellum, thank you again for being on the show.
Yeah. Thanks for having me. I really do appreciate it. Always fun.
Yeah. Everyone, thank you for listening, and we'll catch you on the next episode.